Right. Can you see them okay? Great. Okay. Thank you very much for your introduction, and we're going to get started. So I would like to acknowledge that I live and work on the unceded and unsurrendered land of the Halkomelem speaking peoples, including the Kakite First Nation in the city of New Westminster.
And I acknowledge that the land on which I live, work, and play is the traditional unceded territory of the Algonquin Anishinaabe people.
For disclosures, I'm an employee of Pain BC, and many of our programs and initiatives are funded by the government of British Columbia.
I'm an employee of the Community Addiction Support Association, and CAPSA's projects are currently funded by Health Canada's Substance Use and Addiction Program. So today we will go over some of the challenges and barriers to receiving pain and substance use care. We'll highlight a few of the key intersections between chronic pain and substance use that are important to consider. We will describe substance use health and how it can help provide a fuller, more holistic, and less stigmatizing approach when working with individuals who experience substance use and chronic pain stigma. We will be able to apply a variety of communication strategies when working with people who experience chronic pain and/or who use substances. And lastly, we will be able to share learning resources and supports available to you.
Okay, so chronic pain. In Canada, 1 in 5 people live with chronic pain, which represents nearly 8 million people. And this is information from the Canadian Pain Task Force, who released 3 reports, the most recent one in 2021. So the International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So in its 11th revision of the International Classification of Diseases, the World Health Organization now includes chronic pain as a disease in its own right. And it differentiates between chronic primary pain, which refers to pain that exists despite complete tissue healing and with no identifiable cause, and it's considered a disease in itself. Chronic secondary pain occurs in association with underlying disease processes, such as rheumatoid arthritis, and is further divided into 6 subcategories. So we know the prevalence of chronic pain in Canada isn't equitably distributed. The occurrence of disease, severity of illness, and barriers to care are higher in populations affected by social inequities, racism, poverty, violence, trauma, and other experiences of marginalization. So various forms of discrimination can also lead to compounded challenges in receiving care. And we're going to talk a little bit about that today. Here, this visual is just meant to show what a pain-centered life, how a pain-centered life can occur through a combination of factors, beginning with an injury, surgery, or illness, and factors like isolation, sleep problems, mental health concerns, fear, loss, and grief, as well as experiences of stigma, which we'll be talking about today, loss of income, persistent pain, and inadequate pain management, as well as reduced activities and pain flare-ups and changes in mobility can lead to a life that is centered around pain. The next visual I want to share just shows the complex journey of living with pain. And that means it can start with any of the factors listed there for you on the left. And then in the white bubbles, thought bubbles, you can see different thoughts or experiences that people with pain might have had, and the feelings associated with those experiences in orange. In the teal thought bubbles, you can see that these are things that service providers may have said to people living with chronic pain, and the related impacts of all of these experiences are listed on the right. So again, this is just to highlight that people have a very individual journey through pain, and this journey can be very complex, and it's highly individual as well. Through some of the conversations that I've had with people who experience pain, as well as some of the research I've participated in, I've identified some of the barriers to adequate pain management and treatment, and this is also highlighted in the research, that people who experience pain may face high costs and lack of medical coverage for treatment. There may be long waiting lists for specialized services. There are siloed programs, meaning that people have to seek individual types of treatments that don't always talk to one another. There can be a focus on patient readiness or willingness as a requirement to access programs as determined by a service provider. There can be lack of culturally safe and appropriate programs and services. There's a focus on pills and medication over prescription, and there's stigma about pain and some of the pain treatment options out there. Some of the other barriers include changes in prescribing practices, particularly that we've seen with opioids. There can be mandated or forced tapering without a client's consent. There can be care abandonment where people with complex health needs may be discharged from a healthcare provider's practice without wanting that as an outcome. Healthcare providers may not ask about pain or may not listen to a person's story. They may make assumptions about a person's pain. For example, the labels of drug seeking or referring to people as an addict, as well as a lack of training and knowledge on pain in clinical education programs. There's a focus on moving patients through the system as quickly as possible, and there's the real concern of time and workload constraints as well. So research shows that within the general population, chronic pain remains poorly recognized, underestimated, undermanaged, and associated with social stigmas. In 2021, we were fortunate to hear a presentation by Teresa Newlove, who is the Director of Psychological Health and Safety at the Provincial Health Services Authority. And she shared a quote in her presentation that to experience pain is to have certainty, but to hear about pain is to have uncertainty. So with providers who have more symptom certainty when treating individuals with pain, may find it easier to treat and assess pain. But with complex or chronic pain, symptom certainty can be less certain for those assessing and treating, and even less quote unquote legitimate. And that can result in more complex and ambiguous judgments. And this can also lead to a risk of pain underassessment, underestimation, and undertreatment as well. So this visual is meant to capture, again, the complexity of the journey for people trying to access services for chronic pain. So people may have to wait a long time. They may have to knock on many doors before they can receive the care that they're looking for. They may experience the emotions highlighted there in orange. They may have bumped up against responses from providers that are in the teal thought bubbles. And they may go through a number of different emotions as a result of the difficulty in accessing some services for pain. So the goal is to try to help people get from a pain-centered life to a more balanced life. And this can be accomplished in a number of ways, but 4 of them here that are highlighted include acceptance, so managing pain, getting informed about pain, deciding to move forward, increasing activity through a variety of techniques, including gentle movement and relaxation techniques and paced activity, as well as improved motivation and improved social connections and support, seeking support from friends and family as well. There are multiple consequences of unrelieved acute pain, and this is important to highlight because physiological responses and clinical consequences of unrelieved pain affect every major system in the human body, and that includes the cardiovascular, respiratory, the gastrointestinal, genitourinary, musculoskeletal, neurologic, and immunologic body systems. So acute pain that is not aggressively treated can cause persistent changes in pain processing in the central nervous system, and that can increase sensitivity to stimuli, and that includes allodynia and hyperalgesia. So this can lead to impaired mobility and physical function and increased risk of isolation, detrimental effects on mental well-being, increased risk of sleep disturbances, decreased quality of life, and all of these, through a number of factors that are still being researched and studied, increases the risk of developing chronic pain. I'd like to briefly mention trauma because there's an intersection of pain and trauma that we're going to explore just briefly through this webinar. But trauma, we know, causes negative effects on the nervous system, brain, and it can severely impact physical, emotional, and spiritual well-being even many years after a traumatic experience. And trauma can interfere with a person's sense of safety, their self-efficacy, and ability to regulate their emotions and navigate relationships. So pain and trauma cause greater emotional distress when they co-occur, as well as increased pain intensity, disability, and self-reported physical health problems. We know that many people who have chronic pain have experienced trauma, and experiences of trauma and violence can cause or worsen pain. And this can also increase mental health concerns and the use of mood-altering substances for pain management. And the use of substances may arise as a way of coping with distress and unmanaged pain. But in some individuals, it can also lead to negative health effects, including accidental overdose, drug toxicity, and death. And the BC Coroner's Service released information that more than half the people in BC who died by overdose in years 2016 to 2017 sought help for pain-related issues in the year prior to their deaths. So many people respond well to non-pharmacological treatments and non-opioid medications. Some people might require the addition of opioid medications to manage their pain, and many people living with pain experience stigma because of the complex intersection of pain and substances used to manage pain, and that includes prescribed substances. So the falsely held beliefs that the drug toxicity crisis in BC is driven by prescription opioids and the related changes in policy have and continue to lead people with pain to losing access or having reduced access to opioids for pain management. And in some cases, this can lead a person to turn to illicit drugs to manage their pain, which due to the toxic drug supply is not always a safe option. Research has shown that people living with pain face stigma not only associated with having chronic pain, but also that of using substances, regardless of whether they do or not. And not all substances are stigmatized in the same way. And Lise Dassier in Quebec in 2021 found that Canadians with chronic pain face multiple barriers in pain management, and increased stigma in using opioids, partly because of the ways that the drug toxicity crisis has been portrayed in the media. So I'm going to turn it over now to Ashley.
Thank you. So just building off of what Angela has discussed with us so far is a great example of one of the many important and beneficial uses of substances. So in this case, using substances to address physical health, and then also showing how mental health has an impact on us as well, especially with trauma. And our physical health and our mental health can also impact our substance use. So I know that we're all here today sharing a common goal for better health outcomes for Canadians. So if we're going to talk about health, we need to talk about all forms of health. We talk about physical health without presuming illness. So we can talk about things that we do to maintain or increase our physical health, such as eating healthy, drinking water, going for walks, etc. We're also able to talk about our mental health without presuming a mental health disorder. So we do things on a regular basis in order to maintain our mental health or to increase our mental health, such as meditation, doing yoga, spending quality time with friends or family, partaking in hobbies, etc. But what we don't talk about yet is substance use health. And the importance of substance use health is understanding that substance use can take place without a substance use disorder occurring. And there are many benefits to using substances and also risk factors that take place with substance use that people need to be made aware of. So we talk about health because it is the common thread that Canadians seek for themselves and community. We want healthcare providers to be able to ask the question, how is your substance use health? So that people are able to explore their relationship with substances or possibly address harms related to substance use or be able to address contributing factors to their substance use. And CAPSA has coined the term substance use health so that we can do so without experiencing stigma. Next slide, please. So as I mentioned, substance use takes place on a continuum. There's many ranging ways that people can use substances and different experiences that can occur as a result. So for example, we have at the beginning of the continuum of no use, and that can actually look different between people, between person to person, sorry. So a person not using substances could actually be a person who is living with a substance use disorder and is no longer using substances. Or it could be a person who has not used substances before. But this is also an area where education around substance use and around different pathways to wellness is still beneficial because we're still The information that we acquire about substances and about benefits and about harms will be applicable throughout the continuum. As Angela mentioned, there is beneficial uses to substances. So for maintaining or increasing our physical health, substances can be used to maintain or increase our mental health, And we also even use substances to address substance use disorder. For example, medications that are used for opioid use disorder or alcohol use disorder. People also use cannabis for various beneficial reasons and amongst other substances. And then with substance use comes risks, and there's risks with every substance. Just like there's risks with many things that we do in our day-to-day lives, but we talk about these risks, we educate about risks, and we find ways to manage risks. So for example, consuming alcohol will have risks, whether it be to your health, and so also with cannabis use and prescription medications, there is always going to be risks to our health when using substances. But understanding what these risks are and knowing how to manage them will be pivotal for our health outcomes. And then we can also experience problems or harms related to substance use. And we can experience harms and we can experience risks to substances without having a substance use disorder. So problems occurring could be negative consequences to an individual, to their families, and to communities. And substance use disorder is a diagnosable medical condition that is diagnosed with 11 criteria in the DSM-5. Next slide, please. So what separates substance use disorder from the rest of the continuum for substance use health is that a substance use disorder occurs when a person is compulsively craving, seeking, and using substances, when they're no longer able to make healthy choices, and when they use despite negative consequences to themselves and others. And that is a key factor. It's not an unwillingness to stop, it's not simply being able to. And the distinction is when using substances and repeatedly exposing your brain to substance use, especially if you're using substances in times of trauma or you're experiencing concurrent disorders, adverse childhood experiences, or you're addressing physical health, when you're repeatedly exposing your brain to substances, especially during these times, you are changing the neurochemistry and the neural pathways in your brain that are related to craving, reward seeking, and decision making, all of which go hand in hand with a substance use disorder. Now, if we're going to talk about recovery, or in terms of wellness, achieving wellness, because at the end of the day, we just want to achieve better health. So a person in a journey to wellness with substance use disorder, what that can look like is that the person is no longer compulsively using substances and seeking substance use. They are making healthy choices and they're not experiencing harms or consequences. So all of that can take place through multiple different pathways. So abstinence is one pathway, but there are also several other pathways in order to attain a good health, to attain wellness. So we're also going to talk a little bit more about the pathways, but just wanting to make note that there are various ways to be able to come to a point where you are no longer compulsively seeking and you're making healthy choices and not experiencing these harms. Next slide, please.
So just before Ashley continues, we wanted to briefly mention implicit bias and how it's connected to stigma. So implicit bias refers to attitudes and stereotypes that occur unconsciously, and they inform our thinking, our beliefs, and our behaviors about social groups. Implicit bias occurs involuntarily, and I think that's really important to highlight, and beneath the level of conscious awareness. And this was in a report about stigma that the Public Health Agency of Canada released in 2019. So what's really key is that we're likely not aware that these processes are occurring. We all have some implicit bias, and that bias impacts our judgment and our decision-making and the ways that we engage with everyone around us. So our implicit biases can create barriers to safe and equitable care, even though that may not be our intent. And that's why it's important for all service providers to address and unpack our assumptions. So how are implicit bias and stigma connected? So the stigmatizing practices and discrimination that clients or patients report experiencing from healthcare providers may result in part from implicit bias or unconscious bias. So in healthcare settings, for example, people experiencing chronic pain might be denied medication because of the assumption that they might be drug seeking, or because a healthcare provider makes an assumption about the legitimacy of a person's pain based on a patient's outward demeanor and what they think pain should look like. And I had an experience of this as a clinical instructor when I was with students on an orthopedic surgery floor, and a nursing student did their assessment and came and told me that the patient was rating their pain as an 8 out of 10, but they didn't plan to give the patient any pain because they didn't look like they were in pain. So that's an important assumption to sort of unpack and have a conversation about how that assumption about what pain should look like is impacting the person's experience of care. And healthcare providers are traditionally trained to focus on individual agency and on lifestyle factors without acknowledging the many other factors that impact a person's life, including social determinants of health. So patients have reported feeling a lack of empathy and compassion from healthcare providers at times when they feel blamed for their circumstances, while many of the systemic barriers that contribute to these difficulties and challenges are ignored. And that was also from the Public Health Agency of Canada report. Okay, back over to you, Ashley.
So what is stigma? Stigma is best understood as a deeply held set of false beliefs about a group of people with at least one attribute in common. This allows for the judgment, oppression, and discrimination of those people to take place. So this is done either by overt actions or by silent compliance to those actions. And this is really similar to the bystander effect. So when one person is witnessing the lack of actions, not speaking up against something that is wrong, or hearing stigmatizing language or practices being done, by not actively taking a stance and actively working to reduce stigma, we are influencing the perceptions and actions of other people around us that see this happening. And also we can have the reverse effect of this. So by taking a stand, by actively working to reduce stigma, we can influence others' perceptions and actions towards stigma reduction as well. Next slide. So stigma is experienced at different levels, and you can also experience stigma at different levels at the same time. So we have individual stigma, which is self-stigma. We have person to person, which is the stigmatization of a specific person using substances, so their behaviors, actions, and substance use. Stigma institutionally, which could be an example of stigma experience in healthcare settings. So this is like a systemic approach with policies and practices. And then we have stigma by population. So the stigma of a collective group of people who have a substance use disorder or are using substances. Next slide. So a little bit more further on the types of stigma. Self-stigma is internalized negative beliefs resulting in feelings of shame and worthlessness. And self-stigma is actually derived from social stigma, so social opinions of substance use and substance use disorder. And we also have systemic stigma, as I mentioned, is within the policies and practices that directly impact people who use substances or have a substance use disorder. Next slide. So with the different levels of stigma, there's also further layers of stigma that a person can experience based on individual factors for themselves. So some of these factors can actually contribute to further stigma, while some of these other factors can result in almost like a protective factor to not experience certain stigmas associated with that. So for example, a person of higher education, of higher income, perhaps higher social class, would experience less stigma than a person who is perhaps of low income background, lower social class, and perhaps less educated. There's also specific stigmas attached to race, ethnicity, and culture that are specific to substance use, which would increase that individual's experience with stigma around substance use disorders. And then when you're adding certain of these layers on top of each other, so for example, when you're in the non-minority side, you're experiencing less stigma as opposed to being in the minority of race, minority of culture, of religion, class, sexual orientation. Those factors can pile onto each other and add to your stigmatizing experience. And this is why a one-size-fits-all approach does not work, because there's simply so many layers of stigma that can break down to an individual person's traits and factors for their personal well-being. And this is also why it's so important to have equity in your supports and resources across the substance use health continuum, equitable sources that are also coordinated so that we can address the different factors that can contribute to substance use and the different factors that can change the experience that one particular individual may have with substances that another individual may not have. Next slide, please. So stigma does impact individuals. It impacts our wellness. It impacts our health outcomes. So the impact of self-stigma. People internalize these negative beliefs, and it results in feelings of shame and worthlessness, self-deprecation, low self-esteem. It also results in feelings of decreased self-efficacy, and it arises in feelings of self-doubt regarding our ability to function adequately as a member of society. Next slide. Stigma also impacts our health outcomes. So this is directly from the CPHO report. Stigma is associated with poor health outcomes. It creates barriers to effective care and accessing services, and it puts people at higher risk for chronic stress and poor coping responses. So substance use disorder is one of the only medical conditions that you will actually have a decrease of services or a loss of services entirely as a result of substance use. So when treatments are not working for people experiencing substance use disorder, they are being removed of further treatments and supports, whereas with other medical conditions, you would have an increase of supports if something's not working, or you would have a change in route of treatment if something's not working, but that's simply just not the case with substance use disorder. So we are hoping to flip this upside down pyramid that we're experiencing and be able for healthcare providers to understand that if something's not working for us, especially with recurrence, if someone's experiencing a recurrence, they're often kicked out of their programs in healthcare settings, but recurrence is part of substance use disorder. So we don't want to be punished further for something that is part of the condition that we're seeking to have support from. Next slide. So what we can do about this is supporting individuals who use substances or have a substance use disorder, and this comes with allyship. So being an ally is developing a more accurate appreciation of the realities and possibilities of recovery to overcome negative stereotypes, recognizing the harms done by stigmatization, removing barriers to access to treatments and supports, promoting positive interactions and language, and improving patient outcomes. Next slide. So changing our words, choosing compassion in our language. Next slide. This is just an example an evidence-based example that our language really does have an impact, especially when we are hearing certain language. It's not only the use of our language, but certain language that we are receptive of, that we hear. So this is a study that John Kelly, a Harvard professor, conducted. He had two groups of people in which he provided the same definition for a legalization of a service. So in one group, he used the term safe consumption site, and in the second group, he used the term an overdose prevention site. But given the same definition, the only difference is the language. So for the safe consumption site, 29% of people supported the legalization of this service. But when we changed the language to an overdose prevention site, 45% of people supported the legalization of this service. So a safe consumption site and an overdose prevention site are essentially the exact same thing. It's just a change in the title, in the words that are being used to describe it. And the reason why we see this change and increase of people supporting this is because there is so much stigma that is tied around harm reduction services. So when we hear safe consumption site, that stigma attached to it impacts the people who hear this, and it impacts the support level for this type of service. But an overdose prevention site is something that doesn't have stigma attached to it. It is in itself the name. We are preventing overdoses by having these services available, and people are more receptive to helping when we frame it around health and around prevention of overdose. Next slide. This is just another example, also another study that John Kelly has done. He had taken two groups of people, and only difference was stigmatizing versus non-stigmatizing language. So in the stigmatizing language group, he referred to somebody as a substance abuser and asked a series of questions. For example, if a substance abuser deserves treatment, do they deserve punishment? Are they a social threat? Are they to blame for their substance abuse? And we can see that when we use the stigmatizing language, there's actually an increase of people who believe that punishment would be the best answer, that they are a social threat, and that they are to blame for their substance abuse. And then when we use non-stigmatizing language, when someone is referred to as having a substance use disorder, we can see the shift in the actual increase of more people being receptive to treatment as the option, that they are not a social threat, that they are not to blame for their substance use disorder. But what's also concerning is that we can still see 23% of people think that if you have a diagnosable medical condition, that punishment is still the answer for your substance use disorder. So that's very concerning. And this study has actually been done with public health nurses, so people providing care for substance use and substance use disorders. Next slide. So using non-stigmatizing language is important, and it's not about being nice, and it's not about politically correct. It's about respecting people's worth and dignity, focusing on medical terminology, promoting people's wellness journey, and not perpetuating negative stereotypes and biases. Most importantly, just not hurting people. Next slide. So person-first language is exactly what it is in the title. It's putting the person first before their substance use disorder. So when we refer to people as an alcoholic, a druggie, substance abuser, we are putting that person in a box based on simply their medical condition, and not focusing on the fact that they are an individual person, they have experiences, and they are more than simply their medical condition. So we're essentially putting the person before their substance use or their substance use disorder. So instead of using stigmatizing language and labels, we would use a person who uses substances or a person with substance use disorder. You could also use a person of living experience. Instead of referring to somebody as clean, we would just say a person who is living well with substance use disorder, because when we refer to somebody as clean, we're perpetuating that they were dirty when they were using substances. I also talked a little bit about recurrence instead of being used for the term relapse, because relapse is very stigmatizing, and it puts a lot of blame on an individual who is going through a recurrence. And recurrence is just a recurrence of symptoms of a substance use disorder, and it is a very normal and common part of our wellness journey when you are living with substance use disorder. Next slide.
All right, thank you, Ashley. I have found person-first language so helpful for myself, and I find it helpful not only in clinical practice, but in all aspects of my life. And I think I'm excited that we're talking about it today. And as someone who really values concrete strategies to walk away with, we're providing a number of them for you here today. And these are all ones that I've done based on my own lived experience, but also ones I've collected from the literature that I wanted to share with you today. So some of the strategies that I have found really helpful in my years of experience are to sort of be aware of my own thoughts and feelings before I engage with someone. And that could be, something as simple as checking in with myself before I start the day, before I start a shift, before I start a meeting even, and just being aware of how I'm feeling and how that affects how I engage with people. And we need to consider not only what we say, but how we say it, because we know that nonverbal body language, it also accounts for a huge part of our communication. It's really important to be aware of our own stress levels as well, especially, for example, in busy, complex clinical environments or wherever we happen to be practicing, and that of the other person. What's happening for them right now? Are they in a lot of pain? Are they feeling distressed? And that will affect how they engage with us and how we engage with them. Explaining that we're not there to judge, but to understand. I think that idea too comes up in allyship, is that we're really trying to understand another person's experience and hold space for them to have that experience without judging it or labeling it. Being an empathetic listener and trying to imagine ourselves in other people's shoes. So the idea of perspective taking, really trying to put ourselves in someone's shoes and consider what they might be experiencing. Using open-ended questions, so how do you feel about, and can you tell me more about, will usually elicit a lot more information than simple yes or no questions. Some additional strategies include being comfortable with silence, and everyone has a different comfort level with how much silence they can tolerate in any given interaction, but just allowing for a little more silence, especially if someone is in pain, if they're, for example, or having a hard day, that it may take more time for someone to collect their thoughts. Always explaining what you'd like to do and why, and asking a person's permission. And this is definitely a trauma and violence informed approach to someone's care. It's just allowing the possibility that anyone that you might be working with may have experienced trauma. It's not asking about trauma, it's just allowing that space. And that includes respecting people's boundaries, their physical boundaries, and their emotional boundaries as well. We will make mistakes, and part of this work is, part of what makes it hard is that we often are, I know as a clinician myself, I was always concerned about what if I make a mistake? What if I don't get it right? But in that case, we offer a sincere apology and learn from that experience and try to keep an open mind going forward. Some final thoughts on this is that anticipate that anyone that you're working with, both as a client and as a colleague, may be experiencing chronic pain or may be using substances. Convey unconditional positive regard. That can be a really powerful thing if someone in their lives has not had that experience from those around them. Listen actively to what people are saying. Inquire by following the lead of the person, so allow them to set the pace and work with them on that, even if that means adapting your own approach as a result, and validate all human worth. So other things that I have found helpful is asking people what is meaningful or significant for them. So it could be something as simple as, what can I help you accomplish during my shift with you today? What are your priorities? What's more important for your life, whether short-term or long-term? And what are your goals? Again, just checking our own assumptions and accepting that it's okay not to know. And I think that for a lot of healthcare providers, this can be an area of tension for us because we're trained to have knowledge on a specific topic, but there's so much we don't know, and it's okay not to know and not to have all the answers. And when we're asked a question that we don't know the answer to say to someone, I actually don't know, but let's find out together, or I'll do what I can to find an answer to that question and get back to you. Honor the person's version of the story. Again, this is something that when I spoke with women who experienced chronic pain as a result of intimate partner violence, they mentioned more than once that honoring someone, taking the time to honor their version of the story, was sometimes an incredibly powerful and affirming experience for them. And then when we see and notice systemic inequities and inequalities, to identify them, to name them, to do what we can to try and address them and advocate for change. So some reflective questions from Teresa Newliv that we are using with permission here that I thought were just very valuable to think about in engaging with people, not only in the clinical setting, but generally in life, is that clinical encounter or relationship triggering some kind of emotional response for us based on our own values and morals? And if so, how are those clashing, and how is that affecting how you engage with the person? Are you attributing the experience of pain or the experience of substance use to personal characteristics? And are you holding the outcome of care or success based on your own clinical judgment rather than following the lead of the person? So things to remember that we share with people with lived experience of chronic pain is that their needs matter. And no one knows what you're going through as a client or as a patient or as a person unless you tell them. So that means being candid about how symptoms affect our lives. This means not downplaying symptoms or the situation, and that people have a right to have their concerns heard and addressed. And this also means sharing priorities and areas of greatest concern, and that will help care providers recognize what's important to the person and where they should focus the treatment plan. Ashley, I think you're next here.
Yeah, as a person with living experience, these are some considerations for when providing care for pain and/or substance use. So including clients in their treatment course is a very pivotal factor in positive health outcomes. So making sure that the person who is seeking care has a voice in their healthcare plan, and that it is a partnered approach. So taking into consideration what their substance use and/or chronic pain health goals are. It's also very important to know the different types of chronic pain and/or substance use health supports and services. I talked a little bit about the different pathways to wellness. So ensuring that you are aware of these different pathways so that these are an option for the client seeking supports, so that they can make informed decisions that is met best with their healthcare needs and goals. Also, I talked a little bit about the upside down pyramid. So in courses of treatment, if a treatment does not work, it is the treatment that has failed the patient, not the patient who has failed the treatment. And lastly, an important thing to consider, especially with burnout and having a position as a person providing care for other people, it is very important to stay well while you're helping others.
And on that note, caring for the self, just as Ashley is saying, is hugely important. So paying attention to ourselves and to our own needs as we care for and work with other people. And that includes the idea of self-compassion. Self-compassion means that we have compassion for the self. And for some reason, this was very mind-boggling to me when I learned about it a few years ago, because it was not something I had necessarily learned about in my own training, but seems like such an important thing to practice. Because we need to be able to help ourselves in order to help others in the most healthy way. And mindfulness as well mindfulness is that ability to pause and to reflect in the moment about what's going on for us. And so that idea also incorporates this notion of non-judgmental awareness. So recognizing, acknowledging, and labeling our thoughts and feelings instead of reacting to them. Sharing decision-making and collaboration can be very much a helpful tool. I found my own clinical practice was only enhanced by working closely with my colleagues from various backgrounds and from various health related domains. And I always benefited in the learning that I would have in those experiences. I really believe that sharing decision-making can help to ease some of that load that we feel sometimes if we're trying to make decisions on our own. Filling our own tank, and that will be different for each person, pausing, breathing, and trying to get enough rest, all very important as well. All right, so just as we wrap up, I wanted to briefly touch on what Ariel mentioned at the beginning of today's webinar, but we have ongoing education opportunities that are also highlighted on our website, our Pain BC website, but we have monthly webinars, we have training for healthcare providers on our various programs. We have some referral guidelines and assessment tools. We have the Pain Foundations course for both for primary providers and for allied health providers. And we have a BC Echo for chronic pain. And if you're interested in any of these, please do go to our website for more information.
CAPSA provides workshops and trainings. These are typically delivered to working professionals, government, non-government organizations, students, community health centers, and more. So you're welcome to email info@capsa.ca if you'd like to book a stigma and language session for your organization. We also have All People, All Pathways peer support sessions. They're exactly in the title. We support all pathways to wellness. It's a safe, stigma-free environment that you're welcome to join. These are accessed through the Wellness Together Canada portal, or you can visit the capsa.ca website. We also have gentle movement sessions, so movement towards wellness, also found on the Wellness Together Canada website or CAPSA website. These are designed to improve your movement and mobility and increase mental wellness and substance use health. We also have stigma video resources that can be found on the CAPSA YouTube channel.
And I've included a few pain resources as well in my slide deck that might be helpful to you that you can explore. And CAPSA also has, sorry, go ahead, Ashley.
Yeah, no worries. This is a QR code that you're welcome to scan using your smartphone. The camera app, you can scan it and it'll bring you to a hub of evidence-based resources for stigma and person-first language. Also, again, just putting our social channels. Our handle is CAPSA Canada, and our other services are available on our website.
All right. And that concludes our presentation. Thank you so much for joining us. And I think now we have time for questions. So I'll just wait for Ariel. Hello.
All right, thank you so much for that wonderful presentation. definitely not a small or simple topic, but I think that you covered so many great points in a short amount of time. So I would just invite anyone who has a question to put it in the Q&A. That's where I'll be drawing the questions from to pose to Angela and Ashley. So to start off, we have a question that is about chronic pain in particular. So if someone asks, if someone had untreated acute pain in childhood, would they be more vulnerable to developing chronic pain as an adult? Or is the link between untreated acute pain and the development of chronic pain more time limited? So I wonder, Angela, if you could speak to that one.
Yeah, that's a great question. From what I understand, based on my reading of the literature, people who have untreated acute pain in childhood may be more likely to develop chronic pain as an adult. Again, this is highly individual and is also influenced by a number of factors. I know a researcher, Dr. Melanie Knoll, who has been doing, is that her name, Ariel? Did I get that right? Yeah, based out of Calgary, I believe, and has been doing research on childhood pain. So I would suggest looking into her work as well, because I know that it's new and emerging field, and Children's Hospital also has some great resources on childhood pain and some tools as well that are available.
Great, thank you. All right, is there anything happening to service chronic pain patients who have been dropped from their primary care medical providers, such as helping them to find a new primary care provider or the ability to get them into pain clinics without needing to have a primary care provider?
These are great questions, and ones I'm not as familiar with as our support services team who talk to people who live with pain on a regular basis. I know that Maria Hudspeth, our executive director, as well, has been working on this tirelessly, and it's an area of concern of wanting to ensure that people who experience chronic pain get the medical care and services that they need. And so I'm not sure exactly what's in the works, but that is a question I'd like to follow up on with some people on our Pain BC team and provide perhaps an email that's sent out after this session so that I can have a little more time to pull together some information. Great question, though.
Yeah, and I just put in the chat, one of the things that our Pain BC pain support line does is we have social workers who staff that line, and one of the most common requests that they get is helping folks find a new primary care provider. They also keep track of things like this. We do unfortunately hear quite often of cases where people are having trouble accessing the medications and treatments that they need. So that is one place that you can go if you are in BC.
Thanks for that.
All right, and someone else asks, where would healthcare professionals find resources on how to unpack their biases?
I can jump in. So one resource that I'm aware of is CAPSA and the Canadian Centre on Substance Use and Addiction co-developed a stigma primer that also came with a self-reflection toolkit. So that's one way that you'd be able to learn a bit more about stigma and what stigmatizing views look like. And then the self-reflection toolkit is a really great resource to be able to determine kind of your own personal biases towards substance use and substance use disorders. And then I know that there's also organizations such as the Equip Pathways team in BC that are working on organizational tools to address stigma, but it will also look at service providers' personal biases towards people who use substances. So there'll be other tools available, but that's one that I know of currently that is out.
Yeah, thanks for that. I think there are a few other tools that might be available, so I will also include that in the information email that we send out.
Wonderful. All right, if a client has substance use problems, is it better for them to address these before participating in a comprehensive pain management program? Or is this a discussion that should be client-driven?
Well, talking about substance use can be difficult because of stigma to begin with. So it's important to have a substance use health conversation with your primary care provider, and also understanding that the intersections between the two. So kind of getting a full scope is important in order to properly address better health outcomes. So getting the full picture, it's definitely a conversation that you want to have, because they're very much related and will have an impact on each other. So that's what I can speak to, but it is a conversation to have for sure.
Mm-hmm. And I do agree, Ashley, too, that it should be client-driven as well. All right, do we have time for one more?
Yeah, I think so. And of course, we've got quite a complex question, but in your opinion, how can we break down the silos between mental health, substance use, and chronic pain in our service provision?
I would say coordinating the services as best as possible is one of the ways that I'm aware of now. And it will take a lot of work in order to do that. But because mental health, physical health, and substance use health all intersect, it is so important to have a coordinated, driven approach when addressing these concerns.
Yeah, I completely agree. And also an interprofessional, interdisciplinary collaboration, one where people can access a number of different kinds of services and service providers in one setting. And I think, an example of that in BC that's doing that really well is Kalala Lalem, who have really adopted a really innovative approach to providing care that's a much more interconnected and less siloed than other health settings. And they have a website, I believe, that provides a little bit more of an outline as to why they've adopted that approach.
We do actually have one more question that just snuck in at the end here, so I hope that's okay. And it's a very important one. How do you suggest advocating for a person with living experience who is consistently being neglected by healthcare services?
So this is where allyship comes into play. Being a person who is supporting somebody can be difficult, but making sure that you are standing beside the person. So not advocating for, but advocating with. So building that partnered approach, getting a better understanding on what their goals are, and helping to be a voice for that, not for the person, but in addition to. So two voices together to be able to address these concerns will really help, so that the person who is living or has living experience with either chronic pain or substance use can make sure that these concerns are being voiced. And if a change in care providers needs to happen, or whatever different treatment course may be possible, having that extra voice and extra support person will go a long way for that person's wellness as well as their health outcomes.
Yeah, I fully agree with everything you just said, Ashley. And I think it's really important, that idea of being able to be with people and support people and help them to, understand that their needs matter. And so that might mean having to knock on a few doors before the person's needs are met, but that is well within people's rights to keep asking until they get what they need.
Excellent. Well, thank you both so much. So much great information and lots for us to all kind of chew on throughout the rest of our day. I just ask everyone to please complete our quick feedback survey before you head out today. It should take you no more than 2 minutes, just to let us know what you thought of the talk. And you can also suggest future topics as well. As I said, this recording will be sent out via email along with a list of the resources that we mentioned today. So look for that in your inbox in a couple of days. And otherwise, thank you so much and have a wonderful rest of your Wednesday.
Bye, everyone.
Thank you so much. Take care, everyone.